Hello, this is Metanigma. Today we are studying our brand new section, that is dermatology. This is our first module, that is basics and foundations. We will be covering basics and foundations in this module. Okay, so these are our learning objectives. By the end of this module, you will be able to understand the structure and layers of the skin with their clinical correlation. Why this is important? It's because in dermatology, most of our diagnosis depends upon our clinical observation. So if our clinical observations are not strong, we can't identify the lesions, then we won't be able to make the proper diagnosis. So that's why it is very important to understand the normal physiology and anatomy of the skin. Second important point is identifying primary and secondary skin lesions. Okay, let's begin. This is the structure of the skin. We have got three basic layers of the skin: epidermis, dermis, and subcutaneous tissue, which is also called hypodermis. In this picture, you can clearly see this is epidermis, and then we have got dermis, and finally hypodermis. These are the three layers of the skin. Epidermis is the outermost layer. Yes, you see here, this in this picture, this is the outermost layer. This is the microscopic picture of the skin. Okay, so this is the outermost layer, avascular layer. This is avascular because it doesn't have any blood supply. So where do they get nutrients from? Most of the cells in this layer are dead. But in these ridges here, you can see in these ridges we have got some viable cells that are we will discuss them in the later slides. These viable cells. So you must have a question in your mind that where do these cells get their nutrients from? So basically, they get their nutrients from the dermis. Dermis has blood supply, has blood vessels. So these blood vessels, the nutrients pass from dermis towards the epidermis with the help of diffusion. So basically, the viable cells get their blood supply, get their nutrients from the dermis. Okay, then we have got mainly keratinocytes. Epidermis consists of mainly keratinocytes. These are the cells which are found in epidermis. Then second important point is that it causes superficial lesions. What are superficial lesions? We have got, later we will discuss that there are two different types of lesions, superficial lesions and deep lesions. And if there is impairment or breach in the epidermis, then we will get superficial lesions. This is an important point. Then after examples of that superficial lesion is acne and psoriasis. Next up is the layers of epidermis from superficial to deep. If we move from superficial to deep, these are the layers of the epidermis. Okay, we have got 5 layers: stratum corneum, lucidum, granulosum, spinosum, and basal. Take a look at this. This picture, microscopic picture, shows the cornified layer. This is the first layer. This is the superficial most layer, that is stratum corneum. This is the cornified layer. Next up is the granular layer, but here it's written as the stratum lucidum. Why it's not shown here? That's because lucidum is found only in the skin of palms and soles, but this section of the skin is not from palm and sole, so you won't see lucidum here. You will see the third layer, that is granular layer, stratum granulosum. This is the third layer. This portion is the third layer. Finally, next up is the stratum spinosum. Stratum spinosum is the fourth layer. This is the spinous layer. And then we have the stratum basal. This is the basal layer. We will study these in detail in our next slide. Okay, here these are the layers of the epidermis from superficial to the deep. We have got stratum corneum, stratum lucidum, stratum granulosum, spinosum, and basal. Further, the structure and function. Studying this is important because they are correlated with their clinical presentations. Stratum corneum, it consists of dead flattened keratinocytes. As we saw in the previous picture, that they are mostly dead and flat keratinocytes. Barrier, they provide barrier function, protect against water loss and infections. Once this layer is breached, then the pathogens gets entry into the body. And this is the clinical presentation of stratum corneum. Like if the stratum corneum gets impaired, then we have got scaling as in psoriasis, we have got thick crusts as in eczema, and then finally we have got superficial peeling. All of these are associated with stratum corneum. Second layer is lucidum. It is the transparent layer found only in palms and soles. It provides extra protection against friction. Since palms and soles are mostly subjected to friction, so we have got an extra layer, that is lucidum layer. stratum lucidum. Okay, now the clinical correlates is that thick callosis are basically due to the stratum lucidum. You won't see thick callosis in any other part of your skin. It is only found in palms and soles because lucidum layer is found in these areas. Hyperkeratosis as in soles and palms. Okay, next up is the stratum granulosum. Stratum granulosum, why do we call it granulosum? Because granules are found in this layer. Which granules? Keratinohyaline granules. These are found in the stratum granulosum. Okay, they contribute to the keratin formation. Keratin is formed here and is stored here. Look at this. Keratin is formed. Granular layer is associated with keratin formation, while this keratin is then transported upward towards the stratum corneum. It provides water barrier, and if once this barrier gets impaired, then we have got dry skin, eczema, and ichthyosis. Okay. Next up is stratum spinosum. Stratum, why do we call it spinosum? Because in this layer we have spiny desmosomal connections. What are desmosomal connections? These are like tight junctions between the cells, which may make them compact. So these are like spines. So we call this layer as stratum spinosum. They provide mechanical strength. And what is its correlation? Blisters in pemphigus vulgaris, warty lesions as in HPV infections, all of these are associated with impairment in stratum spinosum. Okay. And next up is stratum basale. Stratum basale consists of basal cells which proliferate and provide further population of cells to the above layers. Now, next up we have melanocytes. Merkel cells regenerates epidermis. Okay. So melanocytes are found in basal layer, and Merkel cells are found, and then regeneration of epidermis is associated with the stratum basale. Once the epidermis gets impaired, breached, or it gets damaged, then the stratum basale, if the stratum basale is intact, then it will regenerate the epidermis. Clinical correlation is that basal cell carcinoma is associated with the stratum basale. Melanoma, as melanocytes are found in the stratum basale, so melanoma will also be found in the stratum basale layer. Okay, vitiligo, hyperpigmentation disorders, all of these structures, all of these clinical presentations will be associated with stratum basale. Okay, so next up is the dermis layer. Dermis is the second layer of the skin. Okay, it consists of thick connective tissue layer beneath the epidermis. What is its location? It lies beneath the epidermis. Of course, we can see here it lies beneath the epidermis. What does it contain? This is important structure. It contains collagen and elastin, which provides elasticity and strength. It contains blood vessels and lymphatics. Blood vessels will provide nutrition both to the epidermis and dermis, and lymphatics will provide immunity, of course. Next up we have nerves. Nerves will provide sensations. All the cold, pain, and other hot sensations will be carried via nerves in these layers. Hair follicles, sebaceous glands, and sweat glands, all of these structures are found in the dermis. Dermis has two layers, papillary dermis and reticular dermis. Papillary dermis, this is the papillary dermis, superficial layer. It is a superficial layer. Then we have got the deep layer, that is a reticular dermis. So these are the two types of dermis. Further, we classify dermis into two types, that is papillary dermis and reticular dermis. Okay, clinical relevance. Nodules and cysts are associated with dermis. Nodules and cysts are mostly found in the dermis. Blistering diseases like bullous pemphigoid, we will study it later in our next module. These diseases are associated with impairment in dermis. Vascular lesions like hemangiomas purpura. You won't find hemangiomas and purpura in the epidermis. Why? Because blood vessels are not found in epidermis. These are present only in the dermis. So hemangioma, purpura, all of these will be associated with. Okay, so next up is hypodermis. Hypodermis is also called subcutaneous tissue or superficial fascia. Okay, it lies just beneath the dermis. Third layer, this is the third layer of the skin, connects skin to the underlying tissue. That is, it connects epidermis and dermis to the underlying tissue. It could be muscle or any other thing like deep fascia. Composition, it consists of fat. Since it consists of fat is mostly found in the hypodermis layer, so it provides insulation. Loose connective tissue, that's why it provides skin mobility. Blood vessels and nerves are also found in the hypodermis. Clinical relevance, abscesses, subcutaneous cysts, and paniculitis, all of these are associated with the hypodermis. So this is Our next topic, primary skin lesions. These are very important. You must understand these skin lesions to recognize the proper diseases or to make the proper diagnosis. Definition. What is the definition? What are primary skin lesions? Initial lesions that appear directly due to skin disease. Those lesions which appear due to the skin disease are called primary skin lesions. Simple as that. Okay, key points are that these are the first manifestation of diseases. Okay, these are caused by pathological changes in epidermis, dermis, or hypodermis. They can exist in either epidermis, dermis, or hypodermis. Okay, they can be flat, raised, pigmented. We will see later in our next slides that these could be flat, raised, or fluid filled, could be of any form. Helps in diagnosis skin disorders. That's why I told you that recognizing these skin lesions is very much important in order to diagnose the skin disorders. These are the types of the primary skin lesions. We will discuss them one by one. This is the first skin lesion, that is macule. Macule definition. You must understand the definition first, because the definition will provide you the whole concept of these lesions. Okay, so this is flat. Macule is flat, non-palpable, color change in the skin. Flat. Take a look at this. This lesion is flat, non-palpable. You can see here that it is almost flat. Since it's flat, so we can palpate it. Color change. This is color change. It is different from the ordinary skin. Okay, and this thing is very important. That is the size. Size will matter a lot, because if the size increases, then we won't call it macule. It will be another lesion. So its size should be less than 1 centimeter. If it's less than 1 centimeter, flat, non-palpable color change in the skin, then we will call it as macule. What are the characteristics of it? No elevation or depression, as it is flat. Okay. Color differs from the surrounding skin, we already mentioned. Examples are freckles, affiliates, petechiae, vitiligo, if small. They could be large, but if they are small, then we can call them macule. Okay, these are the examples. Take a look at this. These freckles, these are flat, non-palpable, pigmented color change. Pigmented or hyper, it could be hyperpigmented or hypopigmented, or if they could be of any color. Okay, and they are less than 1 centimeter, so we will call them macule. And these are the petechial rashes. These petechial rashes are also macules. Next lesion is the patch. Patch, flat, non-palpable color change. Take a look at this. This is the same definition as that of macule. Now where comes the difference? This is the difference. Larger than macule. It is larger than macule. So same lesion, flat, non-palpable color change. But if the size is more than 1 centimeter, then we will call it as patch. It can be hypopigmented or hyperpigmented. It can have irregular borders, no elevation or depression. It is also flat, so there will be no elevation, no depression, but it can have irregular borders like you can see in here. Examples: vitiligo, larger areas. These are of larger areas, more than 1 centimeter. Nevus, depigmentosis. These are the examples of patches. Take a look at this. This is the patch, and then we have a patch here. Okay. Papule. What is papule? This is a small solid raised lesion. The definition will tell you about what is the kind of the lesion. Okay, small solid raised lesion. It is raised. It is not flat. It is raised lesion. Less than 1 centimeter. Again, size matters a lot. So you must remember it should be less than 1 centimeter. Raised lesion, small solid. It can be dome shaped, flat topped, or pointed. It could be red, brown, or any of skin color. Even of skin color, it could be of skin color. Okay, but it must be raised. Examples are warts, lichen planus, insect bites. All of these are papules. Next up is plaque. What is plaque? It is the elevated flat topped lesion, just like we talked in the definition of papule. But here the difference comes in the size. It is more than 1 centimeter. It should be more than 1 centimeter. If it's more than 1 centimeter, if the lesion and flat and elevated, then flat topped but elevated. Okay, elevated from the skin, but its top could be flat. Okay, then that is called plaque. More than 1 centimeter, formed by coalescence of papules. Like papules together, they can form plaque. Firm or slightly soft, may have scales. Examples as in psoriasis, eczema, seborrheic keratosis. We will study these diseases later in our next module, so you don't need to worry about this. But first, you must remember this is the picture. Okay, this is the lesion of plaque. Next lesion is nodule. What is nodule? Nodule is the solid raised lesion. Same definition as that of papule and plaque, but deeper than a papule. It is deeper than a papule. Okay, it is more than 1 centimeter. Its size should be more than 1 centimeter. Firm or soft, can involve dermis or hypodermis, may be mobile or fixed. If it involves hypodermis, then it will be mobile, but if it involves dermis, then it would be fixed. Examples: dermatofibroma, epidermal. Inclusion says rheumatoid nodules like subcutaneous nodules in rheumatoid arthritis, or those are actually nodular lesions, as you can see here in this picture. Vesicle. Vesicles, what are vesicles? These are small fluid filled raised lesions. These are raised lesions, fluid filled. This is important point. This important point. It must be fluid filled, less than 1 centimeter. Again, size is important, less than 1 centimeter. It contains serous clear fluid, thin walled. These are thin walled, so they are fragile, can rupture easily and form crust. These are filled with the clear fluid. So we already called they are fluid filled raised lesions. Thin walled, they have thin walls, that's why they are fragile and can rupture easily. Once they are ruptured, they will form crust. For example, as in chickenpox, varicella, this is the picture of chickenpox lesion. Herpes simplex lesion also appear like this, but it involves one dermatome in herpes simplex, but the lesions are the same. We will find vesicles. Contact dermatitis, it also appear as vesicles. Okay, so next lesion is bulla. What is bulla? Bulla is the large fluid-filled raised lesion. It is also fluid-filled as in vesicle, but its size matters. It is more than 1 centimeter. If it's more than 1 centimeter fluid-filled raised lesion, then we will call it bulla. It contains serous or hemorrhagic fluid. Vesicle must contain serous fluid. Vesicle contains only serous fluid, but here we can have blood as well. Thin-walled, fragile, so it can also rupture and form crusts. Examples include pemphigus vulgaris, bullous pemphigoid, large blisters as in burns. They are all bulla. Next we have pustule. Pustule is the raised lesion, but it is filled with pus, not with the clear fluid, not with the blood, but it contains pus. If it contains pus, then we will call it as pustule. Its size could vary. It is not of fixed size, but it can be superficial or deep, often yellow or white tip, may rupture and form crust. It can also form crusts. Example as in acne, impetigo, and pustular psoriasis. Okay, these can appear with as a pustule. Next up is wheal. Wheal is also a primary lesion, transient edematous itchy lesion. It is itchy. First important thing, it is itchy. Edematous, you will see edema here. Here you can see edema. This is wheal. Transient, size could be variable, usually irregular. Red or pale center with surrounding erythema. The center is mildly peeled, but the surrounding, we have got surrounding erythema. So this is wheal. Appears and disappears quickly. Forms and then disappears. Okay. This is the characteristic of wheal. As in urticaria or hives, insect bites, allergic reactions, they all present as wheal lesions. Next we have got cyst. What is cyst? Cyst is the encapsulated lesion. It has a capsule, okay, filled with fluid or semi-solid material. Cyst contains fluid or either semi-solid material. Its size is variable. Usually cyst is firm. Smooth, dome-shaped, slow-growing. It is usually slow-growing and has smooth surface, as you can see in here. This is a cyst, dome-shaped. Example includes epidermoid cyst, pilar cyst, can become infected to form abscess. These cysts can become infected and they can form once they are filled with first they are filled with fluid or semi-solid material, but once they are filled with pus, then we will call them abscess. These are the cysts. These are also cysts. Okay. Now, this is another important slide, secondary lesions of the skin. All those lesions we discussed earlier, they were all primary lesions. Now we have got secondary lesions of the skin. What are secondary lesions of the skin? These are basically changes in primary lesions due to time, scratching, infection, or healing. Okay, due to all of these things will make the primary lesion secondary, like time, scratching due to scratch, infection or healing often indicate disease progression or complications. For example, you see here, these are the scales. What are scales? These are secondary lesions, like after they are formed after primary lesions. Flakes of keratin from the skin surface. These you can see here, this portion. This is scale. These are scales. Okay, they are formed on the primary lesion. These, take a look at this is also a scratch mark. The first there was a lesion and then patient scratched on it and we have got scales. So as in psoriasis and eczema, in psoriasis and eczema mostly present with scales since they are itchy. So patient scratch them and we have got scales, peeling off of stratum corneum. Crust, next up is lesion is crust. Crust is dried blood, serum or pus on the skin surface. If the serum, blood or pus accumulates on the skin surface and dried up, then we call it crust. Example, as in impetigo, we have got honey colored crust. This is a very important detail. It is often asked in the vivas and it is also often asked in the exams that honey colored crusts are found in impetigo. Ulcers, what are ulcers? Full thickness loss of epidermis. Epidermis is the superficial layer of the skin. So if there is full thickness, I already mentioned that it has got 5 layers. But if all the 5 layers are lost, then we have got ulcer. Epidermis plus dermis and epidermis. If both are lost, then we have got an ulcer. Heals with scarring. It always heals with scarring, as in decubitus ulcer, infected wounds. All these are examples of ulcers. Lichenification. What is lichenification? Thickened leathery skin due to chronic scratching or rubbing. Due to chronic scratching, mostly associated with itch. Since in itch, patients rub a lot, patients scratch a lot. So we have got lichenification, that is thickened there, the skin becomes thick and leathery. That is called lichenification, as you can see here in this diagram. There is the thickened and leathery skin. As an example include chronic eczema, lichen simplex chronicus. Okay. Next up is cloud. What is cloud? Cloud is the raised, thickened scar. You can see here, this is the scar, but it is raised and thick that grows beyond original wound margins. This is the original wound margin, but it grows beyond it, like it is raised. More common in genetically predisposed individuals. So this is the cleide. Cleide normally doesn't exist, but in genetically predisposed individuals, these wounds, when they heal, so they later becomes cleide. Fissure. Okay, fissure. What is fissure? This is our last slide. This is the last secondary lesion. Fissure. What is fissure? Linear crack or split in the skin. As you can see in here, these are the skins. These are the splits and linear cracks. These are called fissures. Heals with scarring. They always heals with scarring. Like as an example in athlete's foot, chronic eczema. In such cases, you will find these fissures, and these fissures are secondary lesions, secondary skin lesions. Okay, thank you very much. This was all. Next, in our next module, we will be talking about bacterial infections. Thank you very much.